We've seen several times now that there are three elements necessary to realize health gains through HWTS. People have to be drinking unsafe water, they have to have access to an effective option for treatment, and they have to apply that treatment effectively and consistently. This last bit is tricky. HWTS is not like vaccination, where you do something once and then you have a long-term protection. It's also not like many chemicals where, roughly speaking, if you reduce the dose by half, you reduce the disease burden by half. Household water treatment is different in that it has to be done consistently and correctly over and over again to realize the health gains, and this poses particular challenges. First, unsafe water. There's actually plenty of it out there. The Joint Monitoring Program of WHO and UNICEF reported that in 2011, 768 million people were using unimproved sources of drinking water, such as unprotected wells or springs or open surface water. But even among those using an improved source, like tap water, a borehole, rainwater collection, improved springs and wells, drinking water is not always safe. Either the resource itself may be contaminated, or water can become contaminated through collection, transport, and storage, as we saw in one of those animations from the first week. It's been estimated that around 1.8 billion people are actually drinking water which contains measurable E. coli or thermotolerant coliforms. So there is plenty of unsafe water out there, and in the discussion on targeting vulnerable groups, we talked about strategies for reaching those with particularly poor water quality. But an option which works well in a laboratory evaluation may perform completely differently in the real world. There are differences, of course, in the person applying the treatment, but also in the environment, the water quality, the containers used, etc. So it's useful to distinguish between efficacy, which is how well something works under ideal controlled conditions, and effectiveness, which is how well it works in the real world. The WHO scheme will measure efficacy, not effectiveness. And there's a good example of the difference between the two in Ecuador, where a long-term research project has examined household water treatment with chlorine, among other things. Now, chlorine is highly effective against bacteria, in particular against E. coli, and the evaluation team, led by Laura McLaughlin, confirmed this with their own tests in 2009, finding LRVs of 3 to 6 depending on the indicator organism. So the efficacy was good. But the evaluation team also found that LRVs were much lower, around 1 in actual households, and that there was no significant difference in LRV between households applying chlorination and households that didn't. Even the measured chlorine residual was not significantly higher in households which reported chlorinating their water. A similar study by the same group, and this paper is by Karen Levy, found that E. coli could be detected in around half of the households reportedly practicing chlorination. And some of the factors they found that correlated with poor LRVs were high turbidity in water, higher concentrations of E. coli in the raw water, and there was also evidence of household-level contamination from poor water handling and storage. Even if a treatment is effectively applied at the household level, it has to be done consistently, day in and day out, and this is a major challenge, both for households to actually do this, and for researchers to monitor and evaluate practices. If you ask people if they've treated their water, they may respond with what they think you would like to hear, especially if you've been involved in the team promoting HWTS in the first place. So self-reported HWTS practice is subjective and probably more useful as an indicator of knowledge or perhaps societal expectations and norms than of actual practice. In some cases, there could be more objective indicators, and chlorine is the best example because residual chlorine can be measured easily and quickly in the field. Others have attempted to observe other kinds of HWTS practice, like seeing if a household filter is wet or appears to be in regular use, or if SOTIS bottles are in the household or present up on the rooftop. Another objective indicator, though, is to just measure the E. coli levels in the raw water and the stored water to see if there has been some kind of improvement in microbial water quality. So objective indicators can help to measure effective use, but consistent use is harder still. Consistent use, or sometimes people say compliance or adherence, means only using treated water for drinking purposes throughout the day, the week, the month, the different seasons of the year. And it's hard to measure this. What you would really like to have would be many repeat visits, what's called a longitudinal study. And this is important, but very difficult and expensive to do. And where it has been done, researchers tend to find that people have very different water treatment practices, even different self-reported practices from one visit to another. A related issue is the long-term use, sustainability of HWTS use. And if an evaluation is done just a few months after an intervention is complete, it probably doesn't give a very accurate picture of the long-term consistent use. HWTS is special because you have to have both effective use and high compliance or consistent use or adherence to get large health impacts. Over the past few weeks, we've seen some really stunning examples of how HWTS has been taken up consistently in certain cases. There were the biosand filters in Cambodia, where nearly 90% of people were using filters, which had been distributed from 6 months to 8 years previously. And here use was defined by self-report, but confirmed with inspection of the biosand filter to see if it looked like it, if it was in use, if it was functional, if it was wet, etc. Then there was the LifeStraw family filter in Zambia, part of the HIV/AIDS intervention, where 96% of the women in the study were still using the filter. 95% of them reported having drunk no unfiltered water or given any to their children on the previous day. And here compliance could have been even higher if rats hadn't eaten 2 of the filters. There was the other LifeStraw evaluation in Congo, which showed more modest compliance, with about 2/3 of people classified as consistent users after 8 months. But nearly all of them reported having drunk some untreated water on the previous day. So this is maybe a medium compliance example. Of course, it's not always such good news, and there are plenty of examples of low uptake as well. It's actually just as important to report and study these to learn about what didn't work. One example is the ceramic pot filters in Cambodia, where only 31% of people were still using filters, as reported in an interview and confirmed by visual inspection. But here the usage was highly dependent on the amount of time that had passed since receiving the filter, and usage was very high in the initial months. It was breakage that was a problem. Before the LifeStraw family filter, there was the LifeStraw Personal. We didn't look at that one in the membrane module, but it's another membrane treatment in which you suck water directly through a filter into your mouth like a straw. And in this evaluation in Ethiopia, only about 1/3 of people reported using the filter in the previous week, and about 1 in 8 people described themselves as consistent users. This study is actually a classic example of respondent bias for diarrheal disease, because the same households reported a 25% reduction in diarrhea, which just isn't plausible with such low levels of compliance. Finally, a large evaluation of SOTIS in Bolivia found that about 1/3 of people were actually practicing treatment, here defined by self-report and confirmed by observation. Now, how can we explain this huge range in compliance, sometimes for the very same product in different settings? Well, household water treatment is a very personal behavior, so behavior change and theories of behavior change are certainly important. But there are also external factors outside the personal domain, such as availability of supply chains, the presence of a supporting policy environment, etc., that are also important in determining use. And these factors will be highly contextual in different settings and different subpopulations within a given setting. Let's take a look now at some of the theoretical frameworks that have been used to explain adoption and uptake of HWTS. A classic text in behavioral change is Rogers' diffusion of innovations theory, first published in 1962 and now in its fifth edition. Rogers analyzed how innovations spread through various communication channels and came up with a list of 5 stages that people progress through as they decide to adopt a new behavior. These are awareness or knowledge, here that they could treat their drinking water with some technology. People should then be persuaded that this would be a good thing to do before they will take a decision to try it out. But even then, it has to be implemented regularly, and people have to, in the end, confirm that this is what they want to do for the behavior to be adopted sustainably. Rogers also identifies 5 attributes of innovations which help them to be adopted. I think he liked the number 5 because he also talked about 5 different types of adopters. But the 5 attributes then are that the innovation should have an advantage over the current practice. It should be compatible with existing values and needs. It shouldn't be too complex either. It's useful if an innovation can be experimented with, trialed on a limited basis. People like to try things out. And ideally, they, and other people as well, should be able to observe the results of an innovation. And these factors together contribute to a greater likelihood of uptake. So that's one framework. Here at EWAG, Professor Hans-Joachim Mosler has developed a theory of behavior change based on psychological theory that's called RANAS, and that stands for risks, attitudes, norms, abilities, and self-regulation. Professor Mosler defines factors which fit into these 5 blocks, which together can determine how likely people are to adopt and sustain a new behavior. In his studies, in his research, his team first measures which of these factors are most important in a given context, and then designs custom interventions to influence the critical factors, and so achieve better uptake and sustained use. Let's look at one more conceptual framework that was developed recently by Robert Dreibelbis and his colleagues, who published a systematic review of theories of behavior change in WASH, and also developed a conceptual framework taking elements from the different contributions reviewed. It's called IBM WASH, and it's not sponsored by a major computer company. It stands for the Integrated Behavioral Model for Water, Sanitation, and Hygiene. The authors consider 3 classes of factors, or dimensions, where the contextual factor represents background factors like access to markets, the policy environment, characteristics of the household and the environment, and so on. And these factors are largely outside of the control of interventions, but have important influences on HWTS uptake and use. The psychosocial dimension considers factors like those described in the RANAS model, which in principle could be targeted and influenced by interventions. Finally, the technical dimension includes the specific characteristics of the HWTS technology to be applied and how these are preferred or not preferred by potential users. Each of these 3 classes of factors, these 3 dimensions, is considered to apply at different scales, 5 different levels, ranging from the individual up to larger groups and eventually the entire society. So in conclusion, we saw 2 models that predict that for HWTS to lead to health gains, the technology has to be applied effectively and consistently. Of course, the drinking water should be unsafe as well, and in order to get behavior change, it may also be necessary that people perceive the water as unsafe, which is a very different thing. Well, effective use can be measured and should be measured when monitoring HWTS. Consistent use is harder to monitor. It typically requires multiple visits and is probably most appropriate at a research level. There are a range of different frameworks for thinking about and achieving and monitoring effective and consistent use of HWTS, including the behavioral change elements, but also other dimensions, such as the contextual or technical dimensions in the IBM WASH framework. The important question, though, isn't which framework is more accurate or comprehensive, but to recognize that consistent and effective use is critical to realizing health gains through HWTS, and to take steps to both promote and monitor actual use. This module has drawn heavily on a number of publications, some of which you have seen in previous lectures, and many of these are freely available on the internet. On the PDF version, you can just click on the hyperlink and get to the actual report or paper. These references are mostly about compliance, either studies that have measured actual use or models linking compliance with health outcomes. And these references are more about behavior change. That could be a nice subject for an entire MOOC, or maybe several MOOCs.